Okay, you want me to get started?
Yep.
Oh, hi, everybody. I'm Valerie Harder. I'm a professor in pediatrics and psychiatry at UVM, Lerner College of Medicine. I lead our health services research team at the Vermont Child Health Improvement Program, or VCHIP. And I'm also part of the Tracking and Evaluation Core of the Northern New England Clinical and Translational Research Network, or NNE-CTR. During this presentation, please feel free to post questions in the chat or hold your questions to the end. I'm happy to introduce today's NNE-CTR seminar on improving perinatal health in Vermont and Northern New England and some recommendations for action. We originally had two speakers today, but now we have one. We're fortunate to have Katy Leffel presenting today from the Division of Family and Child Health within the Vermont Department of Health. Katy Leffel is a nurse and lactation consultant in FCH. At VDH, she focuses on perinatal quality improvement, maternal mortality, perinatal substance use topics. In her role with the Maternal Mortality Review Panel, she has helped develop and drive interventions to prevent maternal death during pregnancy and through the full year after pregnancy ends. She also acts as a liaison to the Perinatal Quality Collaborative of Vermont, PQC VT, which is part of VCHIP, and she supports the Family Child Health Division nursing workforce and VDH's Office of Local Health. She also partners closely with the Family Services Division to adoptive supportive child welfare approaches for birthing people with substance use disorder. And finally, she continues her work of over 13 years in the community, providing lactation support and nurse home visiting with Central Vermont Home Health and Hospice on a per diem basis. So thank you, Katy, for being part of our seminar series today.
Thank you. So I first want to just say that Carol McBride was supposed to be the main presenter today. And so I am not going to try to present on what she was going to talk about today. I'm just going to talk about some pieces that I feel confident in presenting. And I have no relevant financial relationship to disclose or conflicts of interest to resolve. And the data that I'm going to go through today, the first section here is going to be on the Perinatal Public Health Summary Report, which is developed by the Perinatal Quality Collaborative team. This data is all publicly available data, mostly from the birth certificate, the Vermont birth certificate data. And then there's some other pieces of data around some of the programs that we have, the community-based programs in Vermont. And so this is a piece of the data that I know that Carol has access to. She has a lot more depth of understanding with some of the work she does for the Alliance for Innovation in Maternal Health and some of the direct report data from the hospitals, but that is not what I'm going to present today because, like I said, she's the expert in that, and I didn't want to even try to touch it. And I do want to invite anybody from VCHIP who's here today to jump in if they want to add anything, because there's a lot of stuff about the programs under the Perinatal Quality Collaborative of Vermont, which is part of VCHIP. And so I'm glad that they're here today in case I need to have anything corrected or anything like that. All right, so next slide, please. So this is just a little slide on the methods and data notes for the public health report. Just noting that it's birth certificate data for births to Vermonters in Vermont and births to Vermonters in New Hampshire. That's primarily where this comes from. And then there is some additional data sources listed down there on other some of the other programs. Next slide, please. So I'm just going to jump right in to kind of set the stage for what maternal health looks like in Vermont. So again, this is a comprehensive report that the PQC Vermont provided publicly. It's on their website, and I can put links in the chat later for some of these resources that I'm going to go over. But looking at the birth to Vermonters in Vermont and New Hampshire from this 2019 to 2023 time period, 29.7 received WIC benefits during pregnancy. 39.3 used Medicaid as a primary payer for delivery services. 90.2 abstained from cigarette use. 68.3 had adequate prenatal care utilization. There's a little bit more detail on some of these topics later, and go into a little more detail. And then 90.4 breastfed their babies prior to hospital discharge. Okay, next slide. And so this is a scorecard. This is goes over quite a few indicators. Only the ones that were statistically significant trends or changes had the up or down arrows indicating the direction in which the trends were going. And I think that when you look at here, there's a couple of pieces that are concerning, including an increase in pre-pregnancy hypertension and gestational diabetes, a decrease in adequate prenatal care utilization. I'll go into a little more detail about that in a couple of slides. Increase in cesarean sections. The other thing that is interesting here is that you see that with cigarette use, substance use comes into play quite a bit later in some of the later slides, but it shows that although we have an increase in abstention from cigarette use, we have a decrease in people reporting quitting cigarette use who are already smoking during pregnancy. So a little bit of change there, positive overall from people abstaining overall, but if they are smoking cigarettes, quitting is declining. Okay, next slide, please. So this is looking at the sort of trends among where people are birthing and the concentration of birthing. So the figure 1 on the left, all the figures noted here are just pulled directly from the report. So you'll notice that some of the figures have numbers next to them, which are not indicating where they fall in the slide deck, but actually indicating where they fall in the report. So the figure 1 on the left is looking at all the birthing regions in Vermont, and when the pins are the birthing hospitals, and you can see that the highest number of births are in the Burlington at the UVMMC, which is not surprising. The St. Albans and the Barrie district having the second highest rates. So then on the figure 2, you see the breakdown of all the hospitals where people are birthing. So the red is the community hospitals. So that's at this point, this had, this does include Copley because of the time frame was pre-Copley closure. So this includes the 10 birthing hospitals that were open at the time. And then the dark blue is the UVMMC. And then you see at the top, the yellow, the births at New Hampshire hospitals. So you can see that we have a significant number of births in New Hampshire hospitals, which is not surprising when we come to the slide about where our birth hospitals are located in Vermont, the fact that people go across the border to birth. 38% of the births occurred at UVMC, 12% in New Hampshire. We have a fairly robust rate of home birth, so at 3%. And then this last one is that between 3 to 6% of births occurred at each of the 10 community birth hospitals. All right, next slide. So this is looking at two pieces. One is some of the socioeconomic and demographic data on the left. So our education, high school or less, is 28%, some college 17%, and then college or more at 53%. And this is self-report data from the birth certificate data. And then the ages of birth, as you see, our highest age groups are the 20 to 29 and the 30 to 39, and our birthing race and ethnicity demographics align pretty closely with our general demographics for Vermont. And then rurality is also percentage of births that occurred outside of a hospital. That was the 3% on the previous slide. And then on the right, you see the birthing hospitals, and then the hospitals in Vermont without birthing services. And this does reflect the Copley closure. And so you can see along the eastern border of Vermont, there's very few hospitals serving Vermonters. So that's one of the reasons why so many New Hampshire births. And then, of course, Copley closing leaves another large area without a birthing hospital right now. And so Carol McBride actually authored a report on the impact of hospital closures in Vermont, which I will put a link to in the chat so you guys can see them a little more detail on some of this information that you see here. But the lack of access to care is really concerning particularly for our folks who have some of the social determinants of health barriers, transportation being one of them, and just puts specific pockets of Vermonters at a higher risk, especially in the rural regions. Let's see. The question, do you know whether the births that occurred at home were in remote rural areas far? Let's see, sorry. I'll read this one. So I don't have an understanding exactly of where all the home births are across Vermont. I think they're fairly well distributed across Vermont, so I could certainly ask our partners at the Department of Health. They do put out a home birth report, so I can ask them for that information, but I don't have it handy off the top of my head. So this is looking at adequacy of prenatal care utilization, and that's using the Katolchik Index, which looks at a variety of indicators to come up with this prenatal care utilization number. And so you can see on this graph here that it indicates by payer source, Medicaid and private insurance primarily, and individuals with Medicaid as their primary source of payment have lower rates of adequate prenatal care than those with private insurance. And then this comment at the bottom is statewide, about the same proportion of people from rural and urban suburban areas have inadequate levels of prenatal care, but it varies. And generally speaking, individuals living in rural areas with lower educational levels have lower rates of adequate prenatal care in 11 of 12 Vermont health districts. Okay, next slide. This is just a slide on infant mortality in Vermont. We have a lower than average national average rate of infant mortality in Vermont. And there is, again, you see some greater impact on the Medicaid insured infants than in the private insured infants. And figure 14 just talks about the leading causes of infant mortality in Vermont: premature, low birth weight, sudden unexpected infant death, and then birth defects. All right, next slide. This data is pulled from the same report that I was just talking about, but it's a different source of data. It's not the birth certificate data. It's the PRAMS Pregnancy Risk Assessment Monitoring System. And I pulled these three together onto the slide because it looks at depression. So this is a self-reported surveillance data. And birthing people those with a live birth receive this survey in the year after birth. It's a randomized assortment of responses. And so you see here depression rates before pregnancy, during pregnancy, and postpartum with the younger demographic, ages 24 or less, reporting higher rates across all three time periods. And on the right in the box, it talks about what were the barriers for accessing mental health services. And I thought this was an interesting thing to highlight here because I think we all assume that it's about lack of access to appointments because that is what we hear a lot about. It's the need for more mental health supports for folks. But by far the greatest barrier there was reported by the birthing people themselves with a lack of time due to childcare, job, or other commitments. And then at the bottom, you see that 47% of respondents returning to work did not have paid leave. And then 69% felt like their leave was too short, regardless of whether it was paid or unpaid. So I think you can, see maybe a possible connection there around the mental health in the postpartum period, in particular, being impacted by lack of ability to take time off or to engage in services. And Kristen put in the chat, I wonder how much telehealth options could help mitigate some of those barriers. I think certainly that would be an option. I think paying for telehealth, sometimes it is not covered by insurance, depending on the provider. So that can be a huge barrier as well. All right, next slide. This is more PRAMS data. It's looking at substance use in the pregnancy period. So unsurprisingly, marijuana was, or cannabis use was reported in a significant number of folks. So 20% of PRAMS respondents reported using marijuana before pregnancy and 12% reported using during pregnancy, with 5% of women using CBD products while pregnant. And for alcohol, this one is particularly, I think, concerning, considering that it's pretty universally counseled in pregnancy to avoid all alcohol and that there's no safe levels. I think sometimes with the cannabis question, there can be some inconsistent counseling or some mixed messaging that people get, but with alcohol, it's pretty consistently the counseling is it to cease use during the entire pregnancy. So you see here that 30% of PRAMS respondents reported drinking alcohol in the first, this is actually supposed to be the first 3 months of pregnancy, that first trimester, knowing that quite a few folks may, not know they're pregnant yet. And then you see it dropping a little bit down to 11% in the second and third trimesters. And women in younger age groups are more likely to binge drink early in pregnancy, including prior to knowing they're pregnant. But then you see that women age 30 plus had higher rates of drinking in the third trimester at 14%. And so, I think that 30%, we can take that with a grain of salt, knowing that there's a significant number of people who don't know they're pregnant yet. But that 14% in the last trimester is certainly concerning, considering they would have been counseled the entire, let's go back one slide. So yeah. And then just thinking that they would have been counseled on abstinence for that throughout the pregnancy. So that just is an area to think about as we go through some of the other data that we're going to talk about. And then e-cigarettes, people report using e-cigarettes in the 10% in the 3 months before pregnancy, 3% during the last 3 months of pregnancy, and then 9% report using the past 2 years to cut down or stop smoking cigarettes. And we still do can see the cigarette use in pregnancy in Vermont as well. And these numbers for substance use during pregnancy, I didn't put this in here, but they are among some of the highest in the nation for the PRAMS reporting. And we consistently remain some of the highest reported substance use rates in the nation in our PRAMS reporting. All right, next slide. I'm going to switch a little bit. So that was all the data that was presented in that public health report. And some of the next data was also in the public health report, but also comes from some other sources. So I'm switching it up a little bit to talk a little bit about how some of our Vermont projects come together, with some of it with data and some of it with activities for prevention and support. So I'm going to use some of these terms. So I thought it would be good to have a slide to kind of talk a little bit about what you'll be hearing about. So we've talked a lot about the Perinatal Quality Collaborative, which is a nationwide effort, and we get some funding from the federal government and from some other sources to continue that work in Vermont. And VCHIP has had a Perinatal Quality Collaborative formally for about 6 years now. Prior to that, there was always quality improvement projects happening under VCHIP, but it got pulled together and formalized as a perinatal quality collaborative about 6 years ago. So this is just a way to pull together quality improvement projects and be consistent to improve the care for birthing people and babies. And then we have the Maternal Mortality Review Committee, which we call a panel in Vermont, but that is a review of all deaths that happen in Vermont. We review deaths from any cause during pregnancy or for the full year postpartum. And that varies state to state what different states review. Some have higher volume of deaths, so they might review fewer, or they might restrict it to deaths that were caused strictly with conditions related to the pregnancy and birth itself. But in Vermont, we review all deaths. And we also review deaths in cases where there was not a live birth, which is some states also don't review those. And then we have the Alliance for Innovation on Maternal Health. This is another nationwide effort that Vermont engages in as well, that has some established guidelines and some best practice guidance. And then they have quite a few guidelines to help with that standard approach to improve safety and care. And they have that in the form of safety bundles on different topics, which I'll go into a little bit more. And then we have recently received in the last year the Maternal Health Innovation Grant, which is a grant that multiple states received to establish maternal health task forces and supports innovative solutions to addressing maternal mortality and maternal morbidity. Okay, next slide. So I'm going to go through the maternal mortality review panel data. So it's a little bit on the left talking about what the panel is. It was established in 2011, started reviewing deaths in 2012, and they, as I talked about, we review cases through pregnancy, through 1 year postpartum, and we create an annual report with recommendations for change. And those recommendations are produced around the cases we review each year, so they change year to year. So you'll see if you go back through the reports that recommendations often have similar themes, but they might change slightly according to the cases that we review. And the other piece here is that we didn't have enough data because we have so few deaths every year. We have between 2 and 4 deaths a year, which was a positive thing, but it was hard to report on data until the last couple of years. We really were able to have that aggregate data over a decade to better understand some of the picture of maternal mortality, which we didn't really have access to prior to a few years ago because we just didn't have enough data to kind of to develop some themes, but now we do, and we've been really using that data to drive a lot of projects with the Perinatal Quality Collaborative and with other partners as well. So I'm going to go through some of this data that we have. So on the right, you'll see blue is the Vermont data, red is the national data, and our data here is significant just because it really heavily is weighted towards that time period after people leave OB care, so that approximately 6 weeks postpartum to that full year is when we see the most deaths in Vermont, which is just a little bit different than the national average. I think in part we can attribute that to our high quality care and some of our other indicators you saw earlier. We do really well compared to some national data, but things do seem to be something falls apart in the postpartum period for some birthing Vermonters, and we'll go into some of those specific drivers of death in the next few slides. Next slide. What happened here? Oh, there we go. I don't know if I did. Can you advance it? Is it one of those ones where you advance and I think more things? Oh, I guess I did that. I'm sorry. I didn't realize I don't know how I did that, but anyway. So this is looking at some of the socio-demographic indicators here. So on the left, you'll see 93% of the decedents that we reviewed have Medicaid as primary insurance. 87% occurred among residents of rural counties. 71% with perinatal people with a high school or less education. and 55% occurred at ages 30 or older, 19% in the 20 to 24 age group, and then we have never reviewed a death for a person younger than 20. And then on the right, you see the race and ethnicity of the cases that we have reviewed. And of note here is that our deaths are proportionate to our Vermont demographics. So on the bottom, that's what that's showing on the bottom there, is that the green on the bottom is Vermont females of birthing age, and the blue is our pregnancy-associated deaths. So you see it pretty much closely tracks with our general demographics. And the top graphs here are looking at the U.S. general population of birthing age versus the I think that's supposed to say anyway. My point here being that Vermont's deaths are proportionate to their the race and ethnicity demographics of Vermont. All right, next slide, please. So this is getting into the causes of death here. So accidental overdose is our leading cause of death in Vermont, and 48% of the cases reviewed were directly caused by accidental overdose or endocarditis related to IV drug use. And then we do see impacts of substance use in many of the cases we review, whether or not it's the direct cause of death. And most of our accidental overdose include polysubstance use. So the generally speaking, the opioid or fentanyl is the drug causing death, but we see other substances involved. And we don't have data on the number of, we don't have numbers for this, but most of the cases we review include other co-occurring issues like intimate partner violence, mental health, and child welfare system. We've seen homelessness, we've seen human trafficking, we've seen a lot of different other topics as well. And then mental health heavily impacts our case reviews as well, with 90% of perinatal deaths in Vermont occurring among people with a diagnosis of a mental health disorder. And then 13% of all overall deaths are identified as being caused by suicide. On the right is another data point just indicating that the rate of overdose death, the odds of overdose death are about 1.5 times the odds of overdose death of females of reproductive age who did not experience pregnancy. So we do see a disproportionate impact among people who have been pregnant in the past year. Okay, next slide, please. So I put some of our recommendations from the maternal mortality panel from this last year here, just to indicate how you can see a through line to some of the projects that are under implementation in Vermont. So this is, we break up our recommendations for maternal mortality into policy recommendations aimed at the legislature, and then we have another whole raft of recommendations for our community partners and clinical providers as well. But I just included our policy recommendations for the legislators here to give you an idea of some of the topics and the way that we might make recommendations for prevention of future deaths. So we do see intimate partner violence heavily across all of the cases, but in this particular year, we saw it in our case that we had a recommendation around law enforcement advisory board to create a model protocol to standardize responses to intimate partner violence from law enforcement, because we just reviewed cases where there was some inconsistent response that could have possibly intervened in a situation earlier. Although the cause of death was not intimate partner violence, it was heavily impactful in the year before death. And then since we see quite a bit of child welfare involvement across cases, we had a couple of recommendations here to better support people who are involved with the child welfare system and or have their children removed after birth into state care, because we see that as, again, heavily impacting families that have a death in the perinatal period. And oftentimes we review deaths after the child has been taken into custody in that first year. And it's deeply traumatizing to the person who loses custody and the entire family. So we had a couple of recommendations here around better supporting the mental health and substance use resources available to families, and also to have more robust supervised visitation options for families. Next slide, please. And then we recommended expanding the peer workforce and availability of peer support services around mental health and substance use. We have a pretty robust system of turning point centers across Vermont, but the perinatal specific lens is not always there for the peer support system. And we also have almost every year that I've been involved with the maternal mortality review panel, which is 5 years now, have some sort of recommendation around enhanced obstetrical office care coordination. We just see a real gap there with the ability to respond to those needs in the prenatal period in particular, with offices not having the same robust care coordination that some of the other primary care offices across Vermont have. So we really see that as a very clear need across Vermont. And then we have a few other recommendations here around other supportive services. And I have some data on some of these services below as well, but Dulce, which I'll go into a little bit more, which is an embedded care coordination in pediatric offices. And then the Vermont Consultation and Psychiatry Access Program, which is a consult service for providers around perinatal mental health. And then we have one on universal nurse home visiting access and universal access to doula services. I'm going to pause here and look at the chat. Yeah, so Yvonne had some awareness for training for EMS personnel, and I'll actually talk a little bit about that later. I'm not sure of all the acronyms here, but we do have some work around supporting training for EMS and ERs and things like that. And I'll go into that a little bit. Yeah, and then, oh, I see Dr. Meyer here. Oh, good, I'm glad. So anybody feel free from the VCHIP or the PQC to jump in as I'm going through any of this, because Marge is also on the maternal mortality review panel. So if she wants to unmute and say anything, feel free. But yes, we really have the other piece of the care coordination in the obstetrical offices is that we really see the gap also being care coordination between obstetrical and primary care, and that a lot of there seems to be folks who fall through the crack around that time period, because we've seen time and time again that people of birthing age don't always have a primary care provider, and they use their obstetrical provider sort of in lieu of a primary care provider. And so when they leave obstetrical services, that can be a place where people also fall through the crack. Next slide, please. So I'm just going to go through some of the activities that we have around following up on these recommendations. And so the Perinatal Quality Collaborative is one of the primary implementation arms for a lot of these maternal mortality recommendations. So we'll often craft recommendations in the panel, and then the PQC will help support those recommendations with activities, whether it's aimed at clinical providers or community partners. But we do have some other activities around follow-up that we do through the Family and Child Health Division that not necessarily always sometimes includes the PQC and sometimes not. So I'm just going to run through quickly. We do some support with our Family Services Division partners around policy review, particularly around perinatal substance use. the PQC staff and some of the FCH staff are looking at the family care plan and CAPTA reporting, so better care planning for pregnant and postpartum people with substance use and infants that are exposed to substances. And Kayla Panko in particular, who is part of the AIM team and the PQC, we've been working on new mandated reporting training for perinatal substance use in particular, and guidance specific for providers. And then updates to the community response or CHARM team model for communities. There are quite a few communities that do not have one of these teams. I'm not sure if people are familiar with that, so feel free to unmute or pop a question if I use any acronyms or terms that people don't know, but that's another approach to care coordination for pregnant people with substances. And then we also have funded some specific projects around addressing stigma and bias, in particular for perinatal substance use. So we had a therapeutic storytelling project with Lund that produced some really impactful videos that's available on the Lund site. We've been really focusing on integrating that peer support for perinatal people with the Turning Point Center of Central Vermont, which is a peer recovery approach, and we've been working with that particular Turning Point Center to understand how better to integrate peer recovery into clinical spaces. And then we also worked with the PQC to develop perinatal substance use curriculum for community partners, which I'll go into some of this in more detail. I feel like I'm suddenly running maybe a little, I need to go a little faster here. I'm going to get into some of the PQC particular activities here. So this is the Patient and Family Advisory Committee through the PQC, and they have a good number of birthing people from across the state. Oh, sorry, I jumped ahead. Sorry, not telling you what's moving it. Go back to the PFAC. So on the left here is just a little bit of information about the patient and family advisors. And then on the right is a project developed by the PQC, which is a lived experience journey map of perinatal substance use. And next slide. This goes over some recent PQC projects. So that data brief I mentioned earlier that Carol McBride authored, understanding the role of local maternity care in Vermont and some of the impacts of obstetrical closures. The middle here is that curriculum I mentioned earlier, investment in community-based perinatal substance use education. So we really wanted to develop and provide an education for community providers who support perinatal people, but may not have the understanding of substance use, or conversely, somebody like a peer recovery coach who is well versed in recovery but doesn't understand the perinatal specific needs. So this is a 6-module virtually available on the PQC website. And then on the right, you see some of the other supports offered by the PQC, which is some neonatal transport debriefs and in-person clinical skills trainings for partners across the state. And then next slide. So actually I have Marge Meyer here is actually on the AIM team, so I'm glad that she's here, but I also just wanted to highlight the work of the AIM team in Vermont. And next slide, please. So this is some of the work that the AIM team has done. They support all the birthing hospitals in Vermont. We have really robust engagement, which we're lucky in Vermont. Some of the other states have not all their hospitals participating. So we have a great coverage here. And the AIM team focuses on data collection, quality improvement support. They've developed quite a few reference materials, trainings, webinars, newsletters, and patient education materials. So currently, the care for pregnant and postpartum people with substance use disorder is in implementation mode. And then they have the severe hypertension in pregnancy and obstetrical hemorrhage in maintenance mode. So all 3 of those are running in Vermont right now. And next slide. And so this is just a little bit of some of the projects that have come out of the AIM work. So emergency preparedness, so creating toolkits for emergency departments for OB emergencies, drill simulation with the AIM team or OB unit from UVMC, And then there's some of the respectful, equitable care training, so stigma and bias training. We had some national speakers come and talk in Vermont, but we also have an ongoing drop-in sort of conversations happening this year. And we work with the Vermont A1 chapter, which is the nursing association. We have a chapter here in Vermont, and so we've been rolling out the respectful maternity care toolkit across Vermont with a variety of nursing representation from different spaces, including inpatient, clinic, and public health. And then Kayla has developed the AIM Escape Room in a Box. That's a really fun activity for the inpatient units across Vermont, and that's been really popular. And then some of the planning for the 2026 initiatives is universal naloxone distribution at time of hospital discharge, looking at feasibility for that one. And then, like I mentioned earlier, Kayla in particular has been really focused on this mandated reporting guidance for perinatal providers and staff, which is greatly needed. Marge also said, FYI, we've implemented the cardiovascular complications of pregnancy and have worked with single hospitals on a sepsis protocol, which will formalize next year. So the AIM team is doing an incredible amount of work. It's a small but very mighty team. Okay, next slide, please. So this is some of the data from the nurse home visiting program. So I'm just going to highlight a couple of other projects that happen outside of the PQC. This is included in that public health report, like I mentioned earlier, but the Strong Families Vermont is a nurse home visiting program. It is in every region in Vermont. It's implemented out of the home health agencies. And like I said, they have coverage across Vermont. They have provide lactation support, mental health support, maternal newborn nursing assessment, and health education. They also help support infant development and positive transitions to parenthood. It's a program that lasts pregnant through 2 years postpartum. And this just shows some of the numbers that we've seen year to year consistent engagement from families across Vermont, and with 3,093 families served between 2019 and 2025. Next. Actually, one other thing I want to mention about the nurse home visiting is that is an evidence-based program. And so they actually have, we just provide here some of the numbers around engagement, but they have robust data around all sorts of screenings, intimate partner violence, substance use, mental health, lots and infant development assessments. So they have a lot of great, rich data as well. All right, next slide. This is looking at Vermont's doula work. It's sort of a little bit in its infancy in Vermont, although people have been working for many years on doula advocacy. It's really starting to take hold in Vermont. On the right, you'll see that there are 4 regions that are supported with Department of Health dollars and some other dollars to have a community-based doula program. And in those 4 programs, 400 plus families have been served since 2019. Primarily in the Washington County and Franklin County sites, because the other 2 sites are pretty new, but they look to increase wellness, promote healthy attachment, and mitigate the risk and impact of perinatal mood disorders. And then also, additionally, there are other doula approaches. So UVMMC has free labor support through a volunteer doula program. And across the state, there are other approaches as well, and with doulas becoming much more recognized and supported across the community hospitals, but it's just variable whether they're available and what those look like in the community. And additionally, Vermont legislation has taken steps to expand the doula care through Medicaid as well. So really strong doula advocates in our state working to do some of that promotion. Next slide, please. And this is looking, I mentioned earlier, the DULCE program, which is the Developmental Understanding and Legal Collaboration for Everybody. That embeds family specialists and pediatric offices to address social determinants of health and provide support to parents and promote healthy development of infants birth to 6 months of age. They also have some robust data on their sites. As you'll see on the right, those are the DULCE sites in Vermont. They do screenings as well and have some great data available on the sites. And between 2019 and 2024, Dulce served 2,047 families. All right, next slide. And then this slide just is a little bit about a maternal health innovation grant. We have some other projects around maternal health funded through this mechanism. And it's the newest grant that we've gotten in Vermont, and it looks at reducing maternal mortality and severe maternal morbidity. Next slide, please. And some of the grants that we support external to the other things that I talked about is we have one with the Vermont Donor Milk Bank to expand access to donor milk in the community. We see that lactation support across Vermont is really variable, with many regions having very limited access to lactation support. WIC does offer peer counseling as well as having IBCLCs, but unfortunately our WIC engagement seems to be declining year after year, which among eligible people eligible for WIC, which is something that we're working on as well, because they have a lot of connection to community resources and, like I said, this lactation support as well. So that's another area that we're focusing on, but we are supporting the Donor Milk Bank to explore avenues for outpatient community clinics as well. And next slide, please. This is a smaller project, but we had a home health agency that has been providing hypertensive telemonitoring in the home. And so we are supporting them to expand their services and understand how better to create sustainable billing practices. Because right now, they can't bill for telemonitoring itself. I mean, they haven't understood how yet to do it. So we're really just supporting them to have the ability to understand how better to sustain that, so we can maybe bring that to other home health agencies or other folks who might be able to bill for those services. But it's been a very successful project so far. And then the last thing that we're doing, I can go to the second to last slide here, is the Regional Perinatal Quality Collaborative. So we're working with VCHIP again in the statewide PQC to have these 6 regional PQCs, so that people can really focus in on their own regions and what is needed in their own communities, and which may or may not be the same across Vermont. And we're really, really interested in understanding some of that data and evaluation that come up from these PQCs to see what kind of projects they're working on. We are providing a small amount of funding for each site to develop an intervention and look at its sustainability and its replication across Vermont as well. So that's an exciting new project. And I feel like I presented a lot of information, and we have a lot of experts on this call who could also jump in, but that is the last slide I have. And I see that Kristen put in the chat, how is Strong Families Vermont similar or different from the Dulce program? Well, the Dulce program has specialists embedded within a clinic, whereas Strong Families Vermont is a home visiting program. So we go to the families wherever they are, which doesn't have to be in the home. Although it's called home visiting, it can really be anywhere. It's also more extended. It's the prenatal through 2 years postpartum, and Dulce really focuses on the first 6 months after birth. But it's a really nice complement, because many families, we have really robust rates of engagement in pediatric care in Vermont, which is great. And so that's just another place that families are, and not everybody wants a home visiting program or extended supports. Sometimes they just need a touch point in their pediatric medical home. So yeah, and Marge put in, it's very true that Dulce is a gap. If you're not parenting, you're not going to the pediatrician with your infant, then you're not able to access those supports, which is true. That's why I think the focus here on all of those programs you saw is a range of approaches, because one size doesn't fit all for everybody. And some people need everything. Some people might need a nurse home visitor, a doula, and a dose worker in the pediatric medical home. So it's really important to have a range of interventions so people can access what they are comfortable with. Oh.
Thanks, Katie. I encourage anyone, if you want to come on to video, maybe ask your question live. The chat has been fantastic. Thank you for engaging with it, Katie, while you were presenting. That's a really admirable skill. Yes, Elizabeth. Oh, you're on mute.
I saw that I'm on mute. Sorry. So the question is always been for me for a long time is this rich area of implementation projects and all kinds of interesting connections to the community. Which of these projects would lend themselves most to primary population research? Which of these projects would lend themselves best to potentially a clinical trial of something as we go forward? I mean, because a lot of this work is really, like you say, rich data, what have you, but making it into the primary literature, making it into clinical trials has always been a problem. And so when you have people like this together and you have now a CTR like infrastructure associated with the college and what we're doing, how are we going to move to these next steps? How do we do that?
I see. I hope Marge raising her hand to answer the question. I would invite some of the people that are here today to think about that because we do have some, like I said, there are some of our programs that we support are evidence-based in of themselves and collecting data on impacts. Some are, and some of that is qualitative and some of that is quantitative. So there's those pieces. I don't know if that's an answer to your question. It doesn't sound like it is, but Marge, do you have thoughts on that?
Sadly, I'm old, so I pretty much have thoughts on everything. But for this particular one, I would say, yeah, I mean, you could do it. As you know, Liz, I am the idea of studying what I would consider the obvious thing that has to happen always is a double-edged sword because sometimes it just impedes implementation. But very specifically, I would say the most acute gap that we see in our literature right now and in our state, in our stats, is the transition from OB care into primary care.
Yeah.
So you could develop a study by which you say randomized practices to have a very robust mechanism to initiate some kind of a primary care connection and really solidify that follow-up postpartum. That's all doable and measurable. Alternatively, you could certainly say that we as Vermont feel that that this is important enough that we would not necessarily randomize those things, but rather implement them in these hospital-based practices because almost every town only has one OB group. Mm-hmm. And then just do a before and after of whether or not people have primary care, have engaged with primary care appropriately or not. So as you know, I'm more of an implementation and then see how it works and things I know need to happen. But you could do it in either way. But this gap of transition and getting people into primary care by far our weakest link in the system.
Mm-hmm. So in theory, enroll all the women in these various programs, randomize them or pseudo randomize them to the two different interventions, and then track outcomes of various sorts, making consideration of confounding issues like age, like we've noted, rurality that we've noted, not so much for race and ethnicity, but that might be something for, Chittenden County. But be able to do all of these things. And then you could actually publish, in the primary literature, something also talking about all these different things that people have in Vermont, because every time I see one of these meetings, I hear about some new program that I didn't know even existed before, right? There's three of them today that I didn't really knew existed. And I try to keep track of these things because it'd be interesting to be able to do research with them. So even a paper about all that we do and then incorporating it, this intervention would be really great to do. We've got data scientists, we've got, all kinds of population people, we've got statisticians. I see Peter Callis is on the phone. All of these things, we should be able to come up with something.
Yeah, I think just speaking to your point about the range of programs, I think right now we're in a space for funding as far as the, particularly federal funding, the huge influx of money around maternal health in particular, which is great. But it really requires us to think carefully and thoughtfully together about what we're doing across the spaces. That's part of the regional PQC approach, is to understand what's happening regionally so that we can kind of keep a handle on how we're all working together and not replicating interventions or approaches, or trying to utilize all the resources to the best of our abilities. So I think that in one of the pieces that's hard to do as you're have this funding coming in and you're starting up these programs or supporting existing ones, is that piece around research, to like make sure the measurement and evaluation is happening. We do have a maternal child health or family and child health evaluator on our team who's excellent, and she's involved in all of the family and child health projects. So that's also something we really look forward to for the coming years, is having her expertise in evaluation.
So that would be very good. I mean, because a lot of the people who are looking in the space of social determinants of health, right? They don't know, they don't understand the correlates that adversely affect physical outcomes. So now you have a population here where you have things like age and rurality and economics, and you can ask questions like, asthma and pregnancy is better or worse in this population because of that, or cardiovascular disease, or any of these, and try to look at the correlates so you could really superimpose some of these physical things on top of all the stuff that you're actually collecting. And I think that would be a great way for the two sort of centers or collectives of researchers to collaborate to really give us more information about how these things affect biological outcomes.
I see, Marge, you still have your hand raised. Was that just left over, or do you have another question? Okay. We have 1 minute left. I don't know if anyone wanted to sneak in a quick question, or if we should just thank Katy for the time today. This has been really informative. We all appreciate it.
And I just want everybody to know, there's like nothing that could happen with our communication with the health department that can't be attributed to Katy's efforts. And those of you that understand silos in public health and in clinical medicine can appreciate the barriers that she's helped us overcome, because that communication, going from the hospital to community services and engaging in other services and the health department, I just want, honestly, Liz, if there's anything, that's actually the unique intervention, and a lot of it is related to Katy's efforts. And so I just wanted people to know that.
Well, thank you, Marge. And I appreciate you guys all being patient, because Carol McBride was really the main presenter today and would have had, like I said, a lot of rich data, but I appreciate you guys hanging with me today.
It's been wonderful. Thank you so much, Katie. And thank you everyone for your questions.